Everyone, and thank you for joining us for today's program on the early management of achondroplasia. This program is brought to you through a collaboration between Medscape Education and the Society for Maternal and Fetal Medicine. My name is Dr. Andrew Dauber, and I am the Chief of Endocrinology at Children's National Hospital in Washington, D.C. For everyone joining us today, I would encourage you to please drop some comments in the comments box, tell us where you're from, and as we talk about things, please feel free to drop in questions or add in your experience with children with achondroplasia. We'd love to hear from you, and we'll incorporate your comments into our conversation. It's my pleasure to be joined today by Dr. Natalie Merchant and Dr. Shami. Dr. Merchant, will you please introduce yourself?
I'm Dr. Nadia Merchant. I'm at Children's in Dallas, UT Southwestern. I'm a pediatric endocrinologist and geneticist, and I'm looking forward to our conversation today. And please chime in if you have any questions.
Great. And Dr. Shami?
Hello, everybody. This is Dr. Shami. I'm the obstetric and gynecology maternal-fetal medicine at Boston Children's Hospital, and thank you very much for joining us.
Awesome. So we're going to get started, go right ahead. Today, we're going to be talking about the impact that different healthcare providers can have on lifelong outcomes in individuals with achondroplasia and their families, starting early on in the prenatal period. So we're going to talk about the importance of coordinating multidisciplinary care and the role that all different types of specialists can play in helping care for these children. So let's start out, Dr. Shami, and talking about, as a OBGYN, that prenatal period. So tell us a little bit about how someone first might become aware that a child may have achondroplasia during that prenatal period.
That's a great question, Andrew. In the past 30, 40 years, we see a significant increase of the diagnosis prenatally for achondroplasia. And the reason is, first, ultrasound, that means our imaging get much better, and also the genetic tests that we can do. Usually during the pregnancy, we do the early second trimester scan that's coming down, 18 to 20 weeks. Mostly we do not diagnose achondroplasia at that point. And, usually the diagnosis on the ultrasound is coming on the, early third trimester scan is 28 to 30 weeks. Therefore, if you look at the entire world, there's a little bit difference between the prenatal diagnosis on the European side, because mostly they do the third trimester scan. We're not doing too many third trimester scan in the States, but if you do the scan at the early third trimester, and then we're starting seeing of some of the imaging findings, such as short long bones. And mostly it's coming down to the femur or humerus, or you see the bowing of frontal bone bossing. Then these are some elements that you get concerned about achondroplasia, and the next step will be, now you need to go towards your screening and diagnostic test for the genetics.
Got it. Great. And I think that we have to remember that 80% of individuals with achondroplasia have unaffected parents. So, in most of the patients, who we see, there won't have been a suspicion that this would be an inherited condition from one of their parents. So great. So turning to you, Dr. Merchant, this is now a concern's been raised on ultrasound, and you now get the call about a potential patient. Walk us through how that initial conversation goes, and what are some of the next steps in the diagnostic workup.
So I will get the call sometimes from an MFM or somebody who reaches out saying, we have a suspicion for achondroplasia. Sometimes they've already had genetic testing. The reality is with achondroplasia, as you just said, it's later on in the pregnancy that there's suspicion for it. So there are like genetic testing that we can do like earlier on, that is like CVS, chorionic villus sampling, but that's definitely early. And then the question of amniocentesis, if it's a third trimester, like that's also a question that people would want to go through that. But now we have non-invasive prenatal testing, which is really easy, that they can send out, and that's like a cell-free DNA testing, and it looks at through mother's blood, but also the fetal DNA, and it can tell you whether or not there is a genetic mutation that exists, or a variant like for FGFR3 for achondroplasia. And so that is sometimes very helpful, because then it can, even when there's a suspicion, it kind of helps you confirm more likely the diagnosis, and then it helps the family through the process. So that's really been a more recent advancement to have that. And so often MFM's already ordered it, and they've called me so I can do some of the counseling before the results will even come through.
Got it. Awesome. Okay, so if you proceed with that testing now and we've confirmed that this diagnosis is present, we go back to our MFM now. So Dr. Tammy, what do you need to do with during the rest of the pregnancy? Is there some specific, follow-up plan that needs to happen? And then also, what do you counsel the mothers about delivery and what should be done immediately at birth?
These patients definitely need to come to the high-risk doctors, and that's called as maternal-fetal medicine, and come to the tertiary centers that do have resources for taking care of these babies after they're born. During the pregnancy, when we diagnose this, then what we do is we do a serial ultrasound for growth measurement. The head measurement is very important. In some of the cutoffs of head measurement, then if it's more than a 40 centimeter, then we advise the people that, again, definitely the C-section will be the way to go, and it's a safer way to go. The entire pregnancy by itself is not getting, complicated. That means, these patient is not more prone to the preterm delivery. The mom's not prone to having a preeclampsia or anything else. We just do that serial ultrasound. If the head is big, then we recommend it for C-section. But, definitely through that time now, we had the diagnosis. Therefore, we need to connect the patient to the resources that are available. And the patient needs to now understanding of what the baby need after the birth, because that journey just started. Therefore, there's a lot of people need to now start getting involved from, family support group. We need to start preparation of after the birth, how we need to take care of the baby, and many, many other aspects that they need to start understanding with the possible treatment after the birth.
So you're already starting to plant those seeds for the care coordination even before the baby is born. And is that typically done by the MFM, or, is that the geneticist who's identified the testing prenatally? How do you guys work together to make sure that once the baby's born, that team will be in place?
It definitely is a multidisciplinary approach. That means it's not a one-team approach. In our centers, we had a different layers that we know that which one of the patient need to be seen, and mostly done by our coordinators. That means the coordinators start coordinating all of that multidisciplinary, discussion, and then all of these stakeholders will come and see the patient.
Dr. Merchant, any thoughts on that?
Yeah, so I think that it's helpful when the family knows that there's potentially a diagnosis of achondroplasia, confirmed or not, but a concern of skeletal dysplasia. It's a multidisciplinary approach. One, we don't know for sure it's the right diagnosis, but also like preparing what type of car seat, what is the postnatal course going to look like? Knowing the people in the area, because every place is a little bit different and every city is a bit different. Sometimes people live more rural areas. So just knowing like, what are we going to do after birth? I think having a newborn is also really hard. So in some ways, having, if possible, when MFM reaches out to like the appropriate person that they think is going to help coordinate, I think it makes it much easier of a journey for a family, especially those that don't live in a big city, because then they know, okay, we will eventually wind up driving 2 hours for our appointments, and we know who to contact once the baby's born. And so that's kind of, I think, why that whole group multidisciplinary approach is so important.
Yeah, I think it's really important what you mentioned. Like, it really depends on the geography of where the patient lives and whether that person who's going to help them coordinate might be their new pediatrician, or the geneticist or the MFM, but starting to even have that awareness that you need to identify the team who's going to be involved after the baby is born. And Dr. Merchant, I want to touch on something you also said. There's some things that need to be available right when the baby is born, right? For those first few days, there's going to be some tips. So can you just highlight for us again, what needs to be different about the car seat? What other tips do they need just for those as they're going home from the hospital, until they have that first appointment?
So one of the things, I mean, normally there's not always a NICU stay. They will go home with the parents as long as they pass the car seat study. And so making sure that they have a car seat that's firm back, rear facing, they will do, and they pass that. You want to make sure that they're not using like having unsupported sitting, and in general we want that for all babies, but really important because they have a larger head than their body and they're at much higher risk. And there's also other complications because of foramen magnum that's a little smaller. So you want to make sure that they don't have the curved sitting, and also how to handle them when they're feeding. So like providing that back support's really important, and avoiding any kind of mechanical swings, or like carrying slings. Like those are really commonly used these days. So just advising the family like what to look for, and especially when they're buying new things for the baby, you don't want them spending money and then they can't use those things. And I think that that's really helpful, and especially before even the baby's born, just to have all of those things. And I agree that when Dr. Shami mentioned, like, we want to make sure they're delivering somewhere where they could have to do a C-section, because I always talk to like kind of having that birth plan, like what's going to happen if then scenarios with the whole MFM, and for us afterwards, once the baby's born, also like who do they contact? Like, how do we start scheduling appointments? We have to change insurance. All of those things come into play. And I think those are all important things to be thinking about.
To chime in and give us their experience with having had a baby who was delivered with achondroplasia, and how you helped assemble that team. We'd love to hear from you guys as well. So let's talk about that team. So, Dr. Merchant, we know that individuals with achondroplasia need careful monitoring for medical complications over their lifetime, and that there are regular health checks that are needed. But in that first visit, how can the pediatrician help the family in creating that medical home? Who's needed, for that immediate? What are the initial referrals, and what's that team that we need to start to assemble look like?
So, I think that depending on where you are, who's seeing the patient with skeletal dysplasia? Is it the geneticist, or is there an orthopedic? Some places it's more orthopedic driven, and sometimes a general pediatrician that runs like a complex care clinic. So really knowing in your area who that right person is, who's like the coordinator who will help them. And then they do need an MRI, they need a sleep study, they need to get a neurosurgery involved, a good neuro exam, depending on where people are, how closely they're followed. There are different imaging recommendations. So those are all things to be thinking about. And then later on, ENT gets involved. But I also think about like achondroplasia. If we think about other conditions like spina bifida or cleft palate, like we want to make sure they have an appropriate appointment. And just like that, I think in the nursery before they're discharged or by the first appointment at the pediatrician, we need to make sure that they get on the phone and like get that appointment as soon as possible, instead of just waiting to get an appointment that could be 4 or 5 months, because we all know getting a new appointment is not always really easy. So that's also something I say, like, we need to try to get those appointments done as soon as possible so they can get in, and that helps the family overall too. And I'd love to see if anybody has any comments on any of their experiences, or what they think.
That's very helpful. And then, as you mentioned, those complications do continue to occur over the course of the lifespan, and there's certain complications that can occur, are more of an issue at different ages. So we were talking about in infancy, the need for the MRI, the concern for foramen magnum stenosis. You really need the neurosurgery. You need a sleep disorder breathing. You need to be able to do a sleep study in that age group, the ENT. And then you want to tell us a little bit about some of the other players, who might get involved as the child grows up and gets older.
Yeah. So, for the foramen magnum stenosis, I think a good neuro exam, always making sure that the kid's feeding appropriately, no abnormal movement. That neuro exam, that's really important. If parents, I always like warning the parents what to look for is also important. And the head circumference, making good measurements, even at the primary care PCP's office, right, that are important. I think, and then also for the sleep, there's two types of sleep issues. There's a central sleep apnea that you have when you're younger, and that's what can lead to death in a sense, compared to like what you get older, which is like the obstructive sleep apnea. So when you're doing a sleep study, making sure you're doing it at the appropriate place and what they're looking for is also really important. And the MRI that's being done appropriately too, because in achondroplasia, you're looking at the foramen magnum stenosis measurements, and you want to make sure you're doing it somewhere that knows what they're looking for. And then later on, ear infections, you don't want a child not to like be able to hear properly, and so they need to pass their hearing test. So if they have a lot of ear infections, they may not be able to hear properly, and that's why you might wind up putting tubes in, so that way they we optimize and do really well from a developmental milestones. The other thing from a developmental milestones is the achondroplasia developmental milestones are very different. And so we need to know what the appropriate milestones are for achondroplasia, and they may be appropriate. And so you don't want somebody, because they have a little bit of kyphosis, trying to do a brace, because that's not needed. That's just a normal milestone that they're going to have. And those are also important, that the people taking care, like the providers, the different, and the family knows appropriate for the age. And then there's the things that we can talk about later, but like that happens adult and towards as they get older and into adulthood.
So we're going to talk a little bit more, I think here's some tips about how to guide the family to find all these specialists. But I want to get back to something that Dr. Shami said, which I thought was really important, which was about family support groups, right? So you mentioned that, connecting people to family support groups can be really impactful. And what do you think about when the right time is to do that? Is that even prenatally before the parents are born? And how do you connect them to those groups?
It's an excellent question. Definitely, I believe it need to be, before the birth. That means at the time of that preparation. There are lots of, family support, depending to the region that you live, that will be very helpful. And these these family support, many of them went through that process, and they know lots of knowledge. Even some of them are better than some of our physicians. Therefore, they can give some kind of comprehensive picture to this family. And from my experience, many times these families get so close to each other.
That's great. Dr. Merchant, anything to add about kind of family support groups and connecting them? How do you usually go about doing that?
So there's some resources that are on the LPA website, Little People of America, that that there is that like will tell them kind of like even car seats and stuff like that. There's some guidance on there and some of the centers. So I think that that's a really important website to focus the family. And then there's also local chapters, and that might even have meetups. And so I will tell sometimes if I know where the family lives, I'm like, you can look at the LPA DFW. They also have a meetup coming up. And so then a family might decide to show up or not. And I've had parents tell me like later on that they're like, we have 3 little ones that were all born around the same time, and we do we do meetups within those kids, so they feel like they're part of like that they have other kids that look like them. And so I think that it's also very much dependent on the family and what they want. But I do encourage that they do that they do know what the support group can offer, and it can offer different things for different families. And because sometimes there's a lot of new clinical trials also going on and medical management, and people don't know if they want to do it, should they do it, how early to start. There's so many questions, and I think that it's nice having the real experience compared to just knowing what the doctors and providers are saying. So that's why I always encourage the families also.
Yeah, no, so just, picking up on that point, you talked about clinical trials and medications. So there are multiple medications under trials for individuals with achondroplasia. And now there's even one medicine, vosoritide, which has been approved for children starting at birth. Okay. And so vosoritide is improved based on the indication of it being able to improve growth, to increase height outcomes in individuals with achondroplasia. But I think the hope is that eventually it'll show that this medication can potentially prevent or improve the rates of some of these medical complications. And, as you mentioned, some of those complications start very early, like the foramen magnum stenosis. And in order to have any impact on that, one would need to start the medication very soon after birth. So, is that something that parents are discussing even now prenatally? Is that coming up, the ideas of these, whether it's enrolling in clinical trial or starting on medication, when you're starting to have that conversation?
Again, that conversation needs to start prenatally, because as you mentioned, the FDA for that specific medication are approved after the birth. Therefore, the family need to understand. They need to understand the complication. They need to understand where they want to get it. They need to understand what is a follow-up. Therefore, there's lots of steps for that kind of, that medication, and they need to start prenatally that discussion.
And I think it really helps to start prenatally. If we have a prenatal diagnosis, I think just having that appointment to kind of walk through the medical management, because even if they're deciding to pursue like Vosertide, which is FDA approved, starting at birth, we still need baseline studies. We still need to make sure all the appropriate management's going on, and that the family understands what the medication does. And we don't know this; these are all new drugs, and so I think that we still have to do the MRI, and maybe we'll be doing the MRI and sleep study even sooner than you would have if you're not going to do medical management, because we need some baseline studies. And it's, and knowing the healthcare, like navigating the healthcare system is not an easy task. And that's what families will tell you after they've had their baby, just calling, trying to schedule an appointment, getting an MRI appointment on a baby. Like, do you do sedation or not do sedation? These are all things that I think are more complicated than we realize. And you're still having to worry about feeding the baby and cleaning the diapers and all of those things. And so it's a little overwhelming, and I think it helps. I've heard families tell me, like, I just had one recently, and they were like, it was so helpful just to have that kind of like time for us to like get to know the system a little bit and know what we're going to do before the baby's born.
That's great. So I want to get back to building that system for our families now. So we've talked a lot about all of the different players that needs to be involved in the multidisciplinary care team. And I think some of what I'm hearing is that this is going to work differently at every location. And in fact, they might get advice not just from their physicians, but from the other families and from the support groups to find these, people. So, I'd just love to hear your perspectives on, what tips you have about identifying the right people and how that varies by where you live. How do they find who's going to be knowledgeable and help a family with a child with achondroplasia?
So I think it's really, I think that one of the things for skeletal dysplasias in general is that there aren't as many clinics that are very well defined. And it's a very evolving right now, because of the current clinical treatments that are available. I think there's more centers and more expertise being built. And then with the non-invasive prenatal testing, the physicians are learning also, how do we coordinate better? And how do we make sure that our patients get the care they need? So I think that it's a little bit of okay, we know what are the basic management. So if a pediatrician doesn't know, had never had a child with achondroplasia, them just looking at what needs to be done can sometimes be the best way to start, right? Okay, I need to refer to neurosurgery, I need to refer to sleep medicine, and I need to refer to a geneticist or a pediatric endocrinologist if the family wants to do medical management. And then that's kind of starting with the referrals and figuring out who the contact person would be.
Yeah, and in my experience, like you said, there are some well-defined centers, which the physicians can help you find, or through support groups you can help find. But it depends on your geography. And I think for the physicians in the audience also, you don't need to feel that you're alone in trying to manage this, right? So sometimes patients will be able to travel, maybe even just once a year to a center that has a lot of experience. But then you can communicate with that center, before making major medical decisions, to get the advice. And then the team can have, the patient and their family could have the local team, who is going to do the more day-to-day management and help to support the family in between those visits. So I've seen that model as well, where it's not always you're going to one multidisciplinary clinic. And I think the other key part of that, though, is communication, right? So somebody has to help the patient develop that medical home. And who that somebody is different in different locales. Like you said, it could be the primary care physician. It might be an orthopedic surgeon. It might be a geneticist. It might be an endocrinologist. It might be, somebody else in the team who's really going to help them coordinate, but who can communicate to all those people so that there's a kind of unified medical home for the patient. And, as we were hearing from Dr. Shami, that can even start prenatally with the MFM, starting to have those discussions with the family about preparing for the child's further care. I don't know, Dr. Chamby, if you had any other thoughts you wanted to add on to that.
Well, you're right. And then it's not only, MFM needs to get a little bit of the data to the patient, but also connecting to the system. And now is the time to be connected and start having the discussion. It's a hard time for the family because, as you mentioned, majority of our patients didn't know anything about it. And then suddenly out of the blue, they're coming and do the second trimester ultrasound, everything's look normal, but then they do it, early third trimester scan. Suddenly they say it's possible it can be a skeletal dysplasia. And again, it's 80% of the time is a new finding. Therefore, is a big surprise to the family for majority of the time.
Yeah, no, that's such an important point. And so when you're making these conversations, it seems to me like this would be very overwhelming for a family. We talked about all these different specialists that need to be involved, thinking about medical intervention therapy, whether they're going to need, surgical care, in the postnatal period. So besides just referring to family support groups, like what other supports, what counseling, what guidance, do you offer for families with a new diagnosis like this?
These are not easy discussions at all with the family. Therefore, what we do, mostly we give them in a couple of steps. That means, we need to give information. The family needs to start digesting and then have another, consultation, another visit. It takes time and you need to go step by step with the family. And then, through that step, definitely one of the arms that also help us pretty well in our centers is the social workers, because social worker can closely work with the patient. We need to monitor the anxiety. Anxiety is very important. By default, a pregnant woman has a lot of anxiety. And now on top of that, you hit them with a very, new news. And, again, they need to, control the anxiety. Social worker need to help with us. Sometimes we bring our psychiatrists to work with the family to help with that part. And then step by step, you expose them to the other disciplines.
Dr. Merchant, anything you wanted to add to that before we close?
I also talk about postpartum depression when I'm doing the counseling, when I do a prenatal visit, that I'm like, it's a common thing, right? And you suddenly got all this news. And so we want to be there for you as you're going through this. And I talk about the 5 stages of grief, kind of you have something suddenly told to you and you're still having a baby and congratulations, and kind of talking about all the good things that are ahead. But we just want to make sure that everything we do is what's best for the baby and the safety. I think that knowing the complications that can happen, we will hopefully have a better outcome. So that sleep apnea, the foramen magnum stenosis, we know what to do. We just need to make sure we can help support you to get you to the right doctors and the right providers and all the other people that need to be there, which is also making sure you have the support system with the family and your friends. And I think those are things that I think if we verbalize it, it really does help the parents and everybody else involved.
That's great. Well, thank you to both of you, for joining and for your insights. Just to sum up, what I'm hearing is that, the children may be identified often in the 3rd trimester, that we now have non-invasive ways of making the genetic diagnosis using maternal blood cell-free DNA prenatally. Once you have confirmed the diagnosis, you can really start even as early as before the baby is born, start putting in kind of the counseling, those plans in place to assemble that multidisciplinary team that will be needed once the baby's born, starting to have conversations about the potential for medical therapy, and of course, referring to support groups to other parents so that they can start to develop a community and have those plans in place after they're born. So thank you so much. For our audience, thank you for listening and joining us this evening. If you want more information on achondroplasia, please head over to medscape.org for a newly published accredited educational activity. Thank you for your attention, and we wish you a good evening.
Thank you very much for having us.
Thank you, everyone, for joining.